All right, welcome back. This is part 2 of your COO lectures, your well-defined radiopacities with radiolucent rims. In this one, we're going to go on to osteoid osteomas and then osteoblastoma, which is like a larger variant of the osteoid osteoma. Then we'll talk about osteomyelitis sequestra, and we'll finish off with some cases to test how much you've learned. Let's get going. All right, now on to osteoid osteoma. So this one and the next one, there's been a lot of thought of how they're the same lesion, just once it grows beyond 1.5 centimeters, it's an osteoblastoma rather than osteoid osteoma. And so is this just a smaller variant of osteoblastoma? It seems likely. So these ones are kind of known to have that radiolucent rim around them. If you see these examples though, that radiolucent rim isn't always apparent. Here it really is. But then this mixed kind of internal, it still has kind of a fibro-osseous appearance. So it can look like ossifying fibroma, just not quite as big. This is expanding outward, maybe not quite as ball-shaped as ossifying fibroma. And clinically, there's something very distinguishing about these. Severe bone pain, relieved by NSAID drugs, anti-inflammatories. And so that could be used as a diagnostic criteria for these. Typically young age, just like most of the lesions in this lecture. In fact, now that I think about it, I didn't mention the age for ossifying fibroma. And so let's go back here. It is kind of a young adult lesion. There is a juvenile version of this, which is even more aggressive, more expansile, like you saw in that Indian patient. But a lot of times younger than 20, although the conventional ossifying fibroma peaks in the 3rd and 4th decade, so between 20 and 40. And so back to osteoid osteoma, you can see the age range is kind of similar, maybe a little bit younger if we're comparing to the conventional ossifying fibroma, but then consider that there's a juvenile version of ossifying fibroma, and the age range is going to be pretty similar. And so I think this pain is something that really distinguishes this one. Sclerotic periphery, a lot of times you'll have a well-defined sclerotic border around it. As far as our differential diagnosis, if it occurs around the apices of teeth, it could be confused with sclerosing osteitis. We just talked about cemento-ossifying fibroma, and those can look really similar. That's why they're both on the same differential here. Cemento-oblastoma, obviously attached to the roots of teeth. What about osseous dysplasia? If I look at this lesion here, it looks like osseous dysplasia, right at the apex of tooth. It doesn't look like it's attached to the root. I see PDL space intact, kind of a granular calcification internally surrounded by a radiolucent structure. And so just on the imaging of this, it looks like osseous dysplasia. But if I told you that had symptoms, this is a younger patient, it doesn't really look like condensing osteitis. So I hope you wouldn't confuse it with that just based on radiographic appearance. But it's very symptomatic, relieved by NSAIDs. Well, then that's your distinguishing feature, telling you this could be an osteoid osteoma, which are really known to have acute pain that responds really well to those NSAIDs. All right, osteoblastoma. And this kind of sounds similar to cemento-oblastoma, which is handy because I think of it as kind of the osteoid counterpart of your cemento-oblastoma. And we just said distinguishing these from osteoid osteoma is the size. Once it's beyond 1.5 centimeters, start thinking osteoblastoma rather than osteoid osteoma. Same kind of age range, 2nd and 3rd decades, so teens to 20s. And then in this case, when they grow this large, the pain is more dull, not as severe, but that pain is not controlled by NSAIDs. So those things can also help you distinguish. Even though this is not an odontogenic tumor, it often occurs in the tooth-bearing regions. And in this case, as you can see in the TMJ, this is not an odontogenic region. And then this points out why it's in this lecture. Why is it a target lesion? Well, it has that soft tissue capsule around it, that radiolucent rim around it, as we see right here. So differential osteosarcoma, and think when it's near the condyle, maybe chondrosarcoma, those tend to have more of a malignant appearance, being not quite as well encapsulated as we see here. But in some cases, those chondrosarcomas in the condyle can look really well defined. So you might have both on your differential. Osteoid osteoma, what did we say? Smaller. So smaller than what? 1.5 centimeters. And they really respond to NSAIDs. Cemento-osseous dysplasia, well, once we reach the point where it's larger than 1.5 centimeters, osteoblastoma starts to behave more aggressively, more like a true benign tumor, more expansile. All right, and now we're on to our last O of this differential diagnosis, which is osteomyelitis sequestrum, or sequestra is plural. Well, this looks like an occlusal radiograph. This is another lateral oblique, if you don't appreciate that yet. We've seen quite a few of these lateral oblique images where it's taken kind of from below and from the side of the mandible, so you can capture one of the mandibular bodies. And we see here in the mandibular body, this well-defined but very sclerotic lesion here surrounded by a radiolucent capsule. Same thing right here. Just looking at this, it looks like it could be a residual cemento-osseous dysplasia. This one, hopefully you wouldn't think that because where's the tooth-bearing area? Here's the alveolar bone up here. Osseous dysplasia should be above the canal. This looks more like it's in the non-odontogenic region, so don't start thinking odontogenic things. But both of these are just infections in bone. And we'll talk in more detail about osteomyelitis coming up, but I just wanted to include this in this lecture so you recognize that one of those O's from our coup lesions is potentially a sequestrum of osteomyelitis. And this looks pretty bad. Here's your axial slice of a mandible. We have this kind of alternating sclerotic and lucent lesion, these hyperdensities mixed with hypodensities. And these arrows indicate small little sequestra of bone. So what is a sequestrum? When you get a bone infection, which is osteomyelitis, a lot of times the pus starts to destroy bone. It destroys vasculature around parts of the bone, and that bone becomes necrotic. When a bone becomes necrotic, then the body tends to kind of seal it off. The inflammatory infiltrates penetrate around it, and they remove bone. And then that area of necrotic bone becomes very dense, very opaque, very sclerotic. And that's what we're seeing with osteomyelitis sequestra. And so here in a coronal slice, if you don't appreciate what we're looking at, we see the mandible. This looks more like the coronoid process. And so this slice is a little bit uneven, but we're seeing the coronoid slice of the mandibular condyle. And similar to these other lesions, we see a mixed hypodense and hyperdense appearance. There's some periosteal reaction. It's very kind of moth-eaten and irregular. It just looks overall bad, right? And then what this arrow is indicating is there's a sequestrum in here telling you this isn't a malignancy, it's an inflammatory. This is an osteomyelitis, very destructive. But these are chronic osteomyelitis because we see so much opacity to them, so much hyperdensity, so much sclerotic bone. Here's an occlusal radiograph showing again this kind of irregular moth-eaten appearance. But inside here, we're starting to get this isolation of a sequestrum, the sclerotic internal sequestrum. And in this case, we again have this irregular moth-eaten appearance. Maybe there's more sclerotic bone around it. That's one of the ways the bone reacts to infection. But the book talks about sequestrum as the hallmark of osteomyelitis. I like that because it makes me start thinking of Hallmark movies, which I don't watch. But what does the white arrow show as well? Well, that's a periosteal reaction. So you'll see this image over and over. When you have both sequestrum and periosteal reaction, especially the onion skin periosteal reaction, you should start thinking osteomyelitis. All right, time to test you on your knowledge. So this one, on first glance, you have this granular hyperdensity right around the apex of a tooth. It doesn't really look like it's attached to the tooth because I see intact PDL space, and that's surrounded by a radiolucency. So it looks like cemento-osseous dysplasia. Now, if I told you this patient had some pain associated with this tooth, the tooth tests vital. So let's rule out an inflammatory lesion. Let's rule out condensing osteitis, even though it doesn't really look like that radiographically. But that pain is relieved by NSAID medications. Well, that's your sign that it's what? An osteoid osteoma. Less than 1.5 centimeters, so we're not to the size of being a cemento-oblastoma yet. And so this was an osteoid osteoma, even though it looks just like cemento-osseous dysplasia. Younger patient, though, typically cemento-osseous dysplasia you see in middle-aged females. It's most commonly known to occur in African American females, but actually the focal cemento-osseous dysplasia is more common in Caucasians. The more common periapical cemento-osseous dysplasia is more common in African Americans and then Hispanics as well. All right, what about this one? Have you seen this one before? Is this condensing osteitis? You see radiolucencies right around the apices of teeth. Is there anything wrong with the crowns of the teeth? There is some significant wear, but nothing that looks like it's communicating with the pulp. What's the one thing that tells you this is not a periapical inflammatory lesion? It's those radiolucencies going around the outside, right? Typically with a periapical inflammatory lesion, only radiolucency right at the apices, and then it's surrounded by the sclerotic bone that usually has more of a gradual, ill-defined border as it blends with the normal bone. Here, the radiolucency is going all the way around it. What does that tell you these are? It's the common location. So this is our periapical cemento-osseous dysplasia. This one should be easy. Look at how dense that lesion is. Look at how it looks like it has enamel going around dentin. And maybe if we saw more of it, you'd see what looks more like roots. And so, yeah, this is a mixture of an enamel, dentin, pulp. And so this is just an osteoma, complex or compound. Well, the compound ones, really you tell by the appearance. Location can hint you in the right direction, but it doesn't always follow location. But this does look like small little tooth-like structures. And so this is our compound odontoma, which is more common in the anterior and more common in the maxilla. All right, what about this case? Maybe what stands out first to you is this is a young patient, mixed dentition. In fact, are the incisors even erupted? This kid is just approaching 6 years old because that's when you expect to see the mandibular incisors erupt. This was a 6-year-old boy, but where is the lesion? Your eyes might be drawn to the fact that there's no teeth here where all the other deciduous molars are present. So they lost these teeth, maybe they had an infection, but then look down here. Here's the actual lesion we're talking about. Infection from these teeth is probably what led to what's going on here. And what do we see? It's one of our coup lesions. It's a target lesion. Very dense, sclerotic, opaque center. It is very well defined with that radiolucent rim around it. I just mentioned hints of infection from previous existing teeth. And this is a sequestrum from osteomyelitis. All right, what about this one? Hopefully this is easy too. This is the only one we really showed where it's this expansive, pushing teeth apart. Has kind of a granular, cloudy internal appearance, a fibro-osseous appearance with a radiolucent rim around it, but it's growing outward. Oh, look at the canal. That's nice. That gives you a hint about the behavior of this lesion. If the displacement of the teeth didn't already, this is behaving like a very benign tumor tending to grow in a ball shape. This was our ossifying fibroma. And now this one, do you appreciate where it is compared to side? Actually, it looks like 2 locations. I see something going on in the maxilla as well as the mandible. Contrast that with the previous image, and is it well-defined, ball-shaped expansion, radiolucent rim around it like an ossifying fibroma? No, this is more gradual. It's expanding but following the shape of bone. This is more your fibrous dysplasia. And here maybe we don't appreciate much expansion at all. There's probably a bit of expansion with this, but it's expanding more into the sinus, but it doesn't have that ball-like shape like an ossifying fibroma. So this is polyostotic fibrous dysplasia because I see it in both the maxilla and the mandible. All right, so that's it for our coup lections. Cemento-Oblastoma, osseous dysplasia is callbacks we already covered. So we went into odontoma, ossifying fibroma, osteomyelitis sequestrum, and osteoid osteoma versus osteoblastoma, which I kind of pair together because they're only really differentiated by size and how well they respond to NSAID medication. On the next topic, we'll cross into the ill-defined radiolucencies, and we'll talk about our SMELLS acronym and then the new MOOSE box. See you on that next one. Thanks.